This video lecture is going to discuss the events that occur in development after or during and after delivery of the baby. In the previous videos, we took a look at the 3 trimesters. We looked at the first trimester of embryonic development, making the body. The second trimester was rapid fetal growth and maternal changes. The third trimester was changes in the body, getting ready for life outside the womb. So getting the respiratory, digestive, urinary systems ready to go. From there, excuse me, before we deliver, I want to talk with you about what's called premature delivery. We talk about a preemie baby. We define a premature delivery not by age, but by weight. We define a premature baby as a baby that's born weighing less than 5.5 pounds. That's because if, for example, if someone has multiple births, if they have twins, triplets, quadruplets, and the tiny little babies, those babies have the exact same health issues as someone who is just simply born early. And so it's easier for us to think of it in that regard, that if we have a baby that's less than 5.5 pounds, we consider them a premature baby. And so the way that we're going to deal with that is we're going to notice that during that premature time, we didn't finish developing the respiratory system, cardiovascular, immune, and digestive systems. In the past, these babies would have all sorts of health issues all the way up through the first 6 to 10 years of life through these various organ systems. About 15 years ago, they developed a new treatment plan where we would keep the premature baby in the hospital until their original due date, give them a very high protein diet, and do muscle development. We do little, aerobics with them and move the limbs and, do little body massages. And that would stimulate protein development. That would get the liver functioning better, the heart, the digestive, respiratory structures. And so these babies would go home and be much healthier and have a much more normal early development through the next 6 to 10 years. And so that's why this works very nicely. Also, the nice thing about keeping them in the hospital is we can have paid professionals who are doing the high protein diet. You got to understand that a little premature baby is going to be consuming such tiny amounts that you got to sit there and hold the baby and have an eyedropper with this thick protein shake, and for hours at a time. A new mother at home may not have time to do that, but professionals we have at the hospital can. And so that allows us to be able to help Junior grow much better and be much healthier when they're discharged. All right, so let's go with the assumption that we're concerned before we deliver the baby. I want to know if the baby's doing okay. One test I can perform is an ultrasound. An ultrasound uses sound waves that allows me to be able to generate a computer picture of anatomical structures. There's no risk to the fetus. There's no risk to the mother. You can perform it at any time during pregnancy. The downside is it won't give you genetic information. If you're worried that your child may inherit some genetic disorder, this is not going to give you information in that regard. So for that, we'll have to go for something like amniocentesis. Amniocentesis is where we're going to biopsy amniotic fluid. We're going to push a needle down into the amniotic sac, draw out some of the amniotic fluid, which carries some of that sloughed off fetal skin cells. We're going to test those skin cells genetically. We got to wait till at least 14 weeks of gestation. Got to wait for that amniotic sac to get big enough so the needle doesn't stab Junior. And because we're only grabbing a few cells, it'll take 2 weeks to grow up the cells and test them. It's going to take 2 weeks for results. So we won't get results until 16 weeks into gestation. There is a 0.5% risk of spontaneous contraction. We used to think that, that made sense. We're stabbing, a needle through the uterine wall. But we realize now that's actually more due to the excitement of the mother-to-be. And so just first of all, you put a giant needle into her. Second of all, she's excited to learn about something. And so a good ultrasound technician can keep the mother calm, hydrated. As we put the needle in, if we start getting a little bit of spasm, we'll stop for a moment. We'll reassess, decide if we need to do a little topical anesthetic, muscle relaxant. And if we can continue safely, we will. If not, we'll pull the needle out. We'll stop for the time being. In general, amniocentesis is actually very, very safe. But 16 weeks is a long period of time. This is what it looks like and what we're doing. We're using an ultrasound wand to guide us. There goes the needle into the wall to pull out that fluid. Well, we'd like to get information sooner, genetically speaking. So there's a process called chorionic villus sampling. Chorionic villus sampling. we're going to biopsy a chorionic villus. Remember those little clusters of blood vessels from the chorion into the placenta. Since we're moving outside of the amniotic sac, we can do it earlier in gestation. We can do it as early as 8 weeks of gestation. And since we're having a bigger chunk of tissue, we can get you results within 24 hours. So that means we can have results in the first 8 weeks of gestation as compared to 16. However, this is a little bit more invasive. There is a 2% risk of spontaneous contraction. And this is a legitimate 1 out of 50 times this may cause spontaneous contraction. We're going to stop and back off. So you got to be serious about doing a CVS. This isn't something just for grins and giggles, see if, is my kid going to have, dimples. You're doing CVS for more important reasons. This is what it looks like. We're using the ultrasound wand to direct us. We can either take a needle through the abdominal wall, take out a villus, or we can take a catheter up through the vagina, up through the uterine wall, and take a piece off there. But like I said, it's more invasive, and so a little bit more chance of causing that uterine wall to spasm, so you gotta be careful. We can always do blood tests as well. Blood tests can usually give us answers within 6 weeks of pregnancy. Being able to tell us various hormone levels, give us an idea. Well, I should say as early as 6 weeks. As early as 6 weeks, we can start monitoring hormone levels to see what her estrogen, progesterone levels are, to see how stable the uterus is, her corticotropin releasing hormone levels, all those hormones I mentioned at the first video. So we can be taking these blood tests, trying to analyze all of that, helping us to figure out what we want to be looking for. See if there's any red flags concerning us. Let's assume everything's going fine. June is getting bigger and bigger, shoving all of mom's guts up into her thoracic cage. Time to deliver the baby. Now, if mom has high levels of corticotropin releasing hormone or high levels of oxytocin too early, this can lead to Braxton Hicks contractions. These are false labor pains. Now, they are going to be irregular in timing and intensity. They're going to be just spasming all over the place. And the other big sign is there's no dilation of the cervix. And so that's where when the mother-to-be, starts having contractions, we drive to the hospital. The doctor takes a quick look, says, nope, not yet. How do you know? Because there's no dilation of the cervix. And so that's how you know. When it's time and we actually get into true labor, that's when that relaxin is going to cause the cervix to dilate fully. 10 centimeters is full dilation. We're going to have the contractions be progressive, getting faster and faster, bigger and bigger. And true labor itself will go into 3 stages. The first stage is the stage of dilation. I'll say it one more time, 10 centimeters. Make sure you know the units. God help me, I've had students in the past on a test say 10 millimeters. Push a baby out of that. Or 10 inches. Oh, Jesus Christ. And so, no, 10 centimeters. Make sure you know the units. When that happens, the baby's now going to start passing through the birth canal. Stage of expulsion, head will come out first. That's called crowning. That's going to bring the head up. That's the bulkiest part. The rest of the body will just flop out after. A breech delivery is where anything but the head tries to come out first. An arm, a leg, the butt. A breech delivery can get stuck in the birth canal. And that can wind up cutting off oxygen to Junior. We got to quickly try to reposition to see if we can bring them out head first. If not, we'll have to make an incision in the abdominal wall and do a cesarean section. Assuming everything pops out just fine, then we get into the afterbirth stage, and that's where we deliver the placenta. And that's going to stop endometrial bleeding. And there you go. We got a happy little baby. And so we've gone through 9 months of development. We've been able to deliver the baby safely. Want to talk about the neonatal period now. Now we got a newborn. One of the first things we want to do is we want to make sure that the baby is healthy and safe. And so Dr. Apgar developed an assessment that we've been using for several years now. Her name is a perfect acronym. We measure 5 things at 1 minute and 5 minutes after delivery. And for each of these 5 categories, we give a score of 0, 1, or 2. Appearance refers to perfusion of the skin. And so if they're cyanotic and blue, or if they're pink, that gives you a 0 to 2 range. Pulse is getting an indication of heart rate. Grimace is response to pain. So if we do a knuckle rub on the sternum or we flick them on the heel, they should react to that. Activity is just motor activity by themselves. They should be flopping around. Babies should not be just laying there like a rag doll. They should be wiggling around. Respiratory rate, all of these helps us to be able to do a quick assessment at 1 minute and at 5 minutes. Some babies start out really great and after a couple of minutes start to fade. And so we can catch that before it gets too bad. Some babies start out slow, but they're still viable. And by 5 minutes, they have perked up to a higher APGAR score. This has allowed us not to rush into a lot of invasive stuff, try to do a lot of hardcore CPR that could damage chest structures, things like that. And so the APGAR assessment is one of the biggest advances in newborn survival that we've performed in the last 100 years. I mean, it's amazing something as simple as this has had such a profound impact on neonatal survival rates. Now, as the newborn is born, there's going to be changes. We're going to have cardiovascular changes. You and I learned about those before. That's where that foramen valley and ductus arteriosus will close off. The ductus venosus and the umbilical arteries and veins will close off. Now we switch from a fetal circulation to a post-fetal circulation. Respiratory system, the respiratory center in the medulla oblongata will turn on. Now baby starts breathing. Before birth, inside the womb, baby's lungs may have spasmed, but now we're actually going through actual breathing rate and depth. And these will start being monitored through chemoreceptors, baroreceptors, all the structures you learned about before that allows baby's lungs to start actually functioning. Urinary system, we're going to unclench that external urethral sphincter. Now that we've disconnected the allantois, now we're going to start filtering blood through the kidneys, collecting into the urinary bladder, and pushing out the urethra. The immune system will do that immune activation you and I talked about before. We're sending out all those lymphocytes to the thymus and spleen, testing them through that negative selection and positive selection, helping to get rid of any lymphocytes we don't want, keeping the ones we do. And the digestive system, we're going to unclench that external anal sphincter. We're going to turn on the digestive enzymes. And so now we will actually start ingesting food, mechanically and chemically digesting it down to nutrients, getting absorbed across the intestinal wall, and feeding the baby. So lots of busy things going on with our newborn. Ooh, I want to take a moment to talk about something bad. I want to talk about birth defects. Teratogens are agents that cause anatomical defects. They cause birth defects. Teratogens are agents that cause birth defects. One example of teratogens are chemicals. And so alcohol, you hear about fetal alcohol syndrome, where alcohol will damage the development of the central nervous system. Thalidomide is a chemical. This was an anti-nausea medicine that was developed in Europe back in the 60s. A lot of women have morning sickness, and thalidomide wound up being a fantastic anti-nausea medicine. Unfortunately, it also caused a lot of birth defects. It caused a lot of stunting of the limb development. Central nervous system was fine, but the limbs would get very, very stunted. Thalidomide was never approved for prescription in England or in the United States, but there were a lot of American spouses overseas of military personnel who did get thalidomide. So there's a whole generation of thalidomide babies, my age, which are all over the United States now. I actually had a classmate in medical school. John was a thalidomide baby. His lower limbs were normal, but his upper limbs, his hands were full-size and fully functional, but they came right out of the shoulders. Obviously, his central nervous system was smart enough. He got into med school. He now has a wonderful practice and performs medicine as good as anyone. Fetal alcohol syndrome, that's where that neural tube has problems forming. And so how bad depends on how early, how much, and for how long the alcohol retards the development of that early central nervous system. For teratogens, we can also talk about pathogens that cross the placenta or get exposed to the newborn as they travel through the birth canal. So things like the HIV virus, German measles, chickenpox, the Zika virus, all these can cause all sorts of health defects in the newborn. We can look at radiation. Ionizing radiation, which is going to break apart water molecules, making hydrogens and hydroxides, those can damage DNA. So X-rays, gamma rays, these can cause all sorts of genetic damage. And so if you're a dental hygienist, you get pregnant, we're going to keep you away from the x-ray machine. And there you go. And so that takes us through the neonatal period. And then you and I have spent the last 30 weeks learning about the body organ systems that form an adolescent, eventually get us into adult life. We've talked about as we start to move into that old codger stage, we're going to talk about something called senescence. Senescence is the degeneration of organ systems with age. It's the degeneration of the organ systems with age. It's a natural event. Organ systems are going to get slower. They're going to get weaker. They're going to take longer to heal. All that just naturally happens. What controls the rate of senescence you saw there are called telomeres. Now, back inside our cells, in our nucleus, we've got our chromosomes. The end of the DNA, every time this cell goes through mitosis, we duplicate the DNA. Well, every time we duplicate it, it'd be like putting a paper on a photocopier and copying it. It's a little off. We're going to lose a millimeter of edge. That's why we have an inch boundary so we can say that. By the same token, every time we make a copy, we may lose a couple of nucleotides. That's okay because those telomeres, are the ends of chromosomes. They don't encode anything. They're there with the intent of being shredded as the cells divide throughout life. And then you have genetic regulators that monitor the length of telomeres, and that helps us know we've divided this many times. Oh, it's time for puberty. Oh, it's time for menopause. And so those are the things that help determine our advancement through life. There's a condition referred to as progeria. Progeria is a hereditary condition that causes a rapid telomere breakdown. And so these three individuals are all under the age of 10, but they're all suffering a lot of senile age-related defects in their body. They've got a lot of connective tissue defects. They've got atherosclerosis, they've got arteriosclerosis, they've got arthritis, they've got corneal glaucoma, they've got all sorts of health issues. And so it just means that they just shred those telomeres a lot faster, the cells divide a lot quicker, and they age a lot faster. All right. Now, lifespan refers to the maximum age attainable. And so that's determined by the stability of your telomeres. For humans, lifespan is usually between 120 and 200 years. That's the maximum possible. And it just simply depends on how genetically stable your telomeres are. If your family tree tends to have a lot of very old people, or everyone tends to die off a lot sooner. Life expectancy is what really happens. And so lifespan tells us what your potential is. Life expectancy is what really happens. So life gets in the way, makes us, die sooner than we could have. And so for males and females, we're into the 70s and 80s, and the numbers are increasing every year because we're getting better at keeping people alive longer. And if you're careful, heck, like Robert and Leela, dear God, you could be in your hundreds and still be a competitive cyclist or a practicing pediatrician. And so life expectancy can travel far, far into the future as long as you take good care of your body. Boom! Oh my God! We have reached the end of the chapter and the end of the book. That's all the chapters. I've taken you through the entire journey of human anatomy and physiology. So look through the video, watch this, read your notes, rewrite your notes, read the textbook, and let me know if you have any questions. Good luck.